Good afternoon, everyone. It's noon and time to start. It's a great pleasure to welcome you here today to the Fairbanks Ethics Lecture Series. My name is Paul Helft, and I'm the director of the Fairbanks Center for Medical Ethics. I wanted to let you know a few housekeeping items to begin. We're recording and broadcasting the lecture today. We have many people joining us by broadcast. I want to thank those who are continuing to enhance your education in the field of ethics. The groups today that are joining us include IU Health Ball, Jay, North, the IU School of Dentistry, the Peyton Manning Child Life at St. Vincent, and Reed Health. If you wouldn't mind silencing all of your electronic devices, and please leave the auditorium if you have to return calls. There are telephones available in the vestibule just across the hall. Our speaker today, Dr. Leland, has no relevant financial conflicts of interest to disclose. So it's a great pleasure to introduce my colleague, Dr. Brian Leland, who's the director of the Clinical Ethics Fellowship with the Fairbanks Center for Medical Ethics since August of 2017, and completed his ethics fellowship in May of 2015. He joined the IU School of Medicine faculty in 2016. He completed a general pediatrics residency and a fellowship in Pediatric Critical Care Medicine here at Riley Hospital. He currently serves as an Assistant Professor of Pediatrics in the Division of Pediatric Critical Care Medicine. He is an Indiana native and committed to serving the needs of his home state of Indiana, and completed the entirety of his medical training at the Indiana University School of Medicine. He is a second-generation physician and pediatrician and gained an appreciation for the practice of medicine at an early age with a particular interest in the care of children. He was drawn into the field of pediatric critical care when he identified clinical ethics to be of great significance. Implementing his formal training and interest, Dr. Leland has been tasked with pediatric ethics program development for the Department of Pediatrics and Riley Hospital for Children, and he's going to be speaking today on pediatric ethics at Riley Hospital for Children at IU Health, consultation review, needs assessment, and future directions. Please welcome Brian Leland.
Thank you, sir. All right, so I have this microphone on. Can everyone hear me okay? All right, awesome. So almost exactly 3 years ago today, I gave a FCME ethics lecture here on a project I was doing as a critical care fellow, and I see Dr. Beardsley in the audience, and the funny story about that, which you may have already heard, is that I was on call that evening, and so I brought the suit that I was going to wear, only to find out once I arrived here that I brought the suit coat only, and so I had to borrow Dr. Beardsley's pants. It was a little bit awkward, but and then this morning, Dr. Courtney Fry, who's one of my office mates, was on call last night, and as she's leaving, she said, "Good luck with your presentation. Things are already off to the right start. You're wearing pants." So without further ado, let's get into pediatric ethics here at Riley. And as Dr. Health said, I do not have any conflicts of interest or disclosures, but if there's anyone who would like to provide me with some, I invite you to come join me at the podium after the presentation, and we can have that discussion. All right, so when I came on as faculty here, I sat down with Dr. Lane Cox, who's now CMO, and had a discussion with her about strengthening ethics infrastructure here at Riley. And I think to discuss these objectives, we should talk a little bit about this through essentially a story, and that is, she said, build an ethics program here. And I said, okay. And so I had to break that down. And to me, what that means is knowing where we've come from, knowing where things are currently, and then using those pieces of information to determine where we're going to go. And so each of these respective objectives accomplishes those things. So we'll explore the history of ethics consultation, and then talk about a historical consult review that we did, and then talk about a clinical ethics needs assessment that I performed, which can only be informed by understanding what a healthy culture of ethics at an institution would look like. And then we'll talk about the implications of those findings and how we can use them to inform program development moving forward. All right, so for those of you who don't know, Riley Hospital was founded in 1924, right? And from 1924 until 1983, there was no formal ethics infrastructure in place. And while technology was rapidly progressing, the extent of the opportunity for ethics consultation consisted of respective providers discussing challenging cases and trying to do what was best. However, in 1984, pardon me, the first semblance of an ethics committee was formed, and that was called the Infant Care Review Committee. And this was formed, pardon me, in response to both the President's Commission for the Study of Ethical Problems in Medicine, which was prompted by a case that everyone should have some familiarity with called Baby Doe, which was a child born in Bloomington, Indiana with Down syndrome, esophageal atresia, and tracheoesophageal fistula, who's ultimately was allowed to die, and there were concerns about the appropriateness of that intervention and or lack of intervention if it was based out of discrimination. And so both the President's Commission for the Study of Ethical Problems in Medicine and the AAP shortly thereafter made recommendations that hospitals should have ethics committees to review difficult cases. And so this committee was formed, headed by Dr. Schreiner, who at the time was the chair of pediatrics, and it was a 9-person committee consisting of 4 faculty physicians, a nurse, a social worker, an attorney, a community person, a hospital administrator, and then Dr. Schreiner leading the committee. And there were specific mandatory triggered consults, if you will, and then the remainder were at provider's discretion. And the triggered consults or mandatory consults were for disagreement between parents and physicians over withdrawal of life-sustaining treatment, and then treatment decisions for infants with specifically meningomyelocele or Down syndrome, where the infant would receive treatment for a disease process without question if they didn't have those 2 underlying diagnoses. They met about 5 times a year for the first 10 years of its existence, and then I couldn't find data to tell me more about how frequently they met thereafter. But they would convene this group, review, discuss, have key stakeholders come and share their opinions, and then arrive at a decision by vote. And as Dr. Schreiner explained to me, it was extremely unusual for votes to be close, and if they were, they felt that additional discussion was necessary. So this continued through the early 2000s, and in conjunction with that, in 2001, as the Infant Care Review Committee continued, the Charles Warren Fairbanks Center for Medical Ethics was founded. And this was a grant awarded to Dr. Stephen Ivey, who was a VP for IU Health, who said, you know, it would be really nice to have a hospital-embedded ethics center. And that grant was funded with a significant endowment to initiate and start the Charles Warren Fairbanks Center for Medical Ethics. And Dr. Paul Health was thereafter hired in 2004 as the fearless leader, and he and Dr. Ivey then in 2007 hired a nurse ethicist, Lucia Voschel, somewhere around here, I think. There we go. And she started working on nursing ethics programming in 2007. Additionally, at that time, in 2007, 2008, Dr. Voschel, whose background is in nursing for neonatology, said, you know, let's look at seeing if we can work collaboratively to restructure the consultations infrastructure for Riley to better mirror some of the well-established programs nationally. And so she took on the task of trying to have a pediatric-specific ethics consultation service, and trained over a 4-month period somewhere between 10 and 14 personnel at Riley who were then responsible for consultative efforts for ethics. And FCME faculty were available for consultation and to participate in high-stakes cases. Unfortunately, this was a strictly volunteer group, and so it dissolved pretty quickly. And thereafter, since 2009, the Fairbanks Center for Medical Ethics has assumed all ethics consultation responsibilities for the academic health center, including Riley Hospital for Children. And we embrace a small team model, and I'll share with you exactly what that looks like. But ethics consultation services are available 24 hours a day, 7 days a week, Christmas, New Year's, 4th of July, etc. We're just like any other consultation service. You call the operator and you say, I need to speak to the ethics consultant on call. We get a page to, I think it's a text now, to our phone, and we'll get back to you within 15 minutes and move forward from there. Every team will have a supervising consultant that is one of a handful of FCME faculty with formal ethics training, and they all have some level of protected time for their ethics responsibilities. Usually, we will have an ethics fellow on the team. Our ethics fellowship is a 9-month program, and each of our fellows will do a month of consult experience. And then the remainder of the team is comprised of volunteer consultants, and whether that's past ethics fellows or individuals with some level of ethics training that want to be involved. So a call comes in, it's fielded, information we take down, and then move through the consult process. So talk with key stakeholders. Oftentimes we'll attend family care conferences. We may mediate a medical team meeting where there is discordance and thoughts about the most appropriate plan. And then we will ultimately use an analysis to arrive at a set of recommendations to help guide the medical team. What you see right here is the ethics consultation data summary sheet, which is essentially what I consider the Cliff Notes version of our consult experience. And it just lets us jot down demographic information, how much time we spent, what types of issues needed to be addressed. And then on the back of it is a selection where the consultant is encouraged to highlight all appropriate and pertinent ethical issues that were necessary to providing a framework for the analysis that inform the recommendations in the consult note. So we have one of these for every consult that we do. And so I said that we needed to know where we came from. And so we've just talked about the history of ethics at Riley. And I think what mattered in addition was what types of consults are we seeing? And the amount of data for this nationally is pretty limited. There are just a handful of studies. And so we had this data bank with all the information from all those consultation summary sheets, and we said, all right, well, let's look at that. And so starting in January of 2009, which was when the process that I just described was formalized, up through April of 2017, we reviewed all of the consultation data summary sheets for pediatric ethics consultations, and that included here at Riley and then the affiliated NICUs at the Academic Health Center. Inpatient, outpatient, you just had to be less than 18 years because 18-year-olds are adults. Even though we have a lot of them here, we may reconsider that inclusion criteria. We found 165 cases that met these inclusion criteria, and I highlight that because to date, this will be the largest review of pediatric ethics consultation published nationally, and we're excited to share this with the ethics community. So what did we collect? General demographic information like patient age, what their diagnosis was, who's requesting the consults, where are these patients located, and what's happening in the process of the consultation. So what did we find? Well, we found pretty clearly over this 8.5-year period that the utilization of the service was increasing. Don't panic about this massive drop in 2017 because it only reflects 4 months of data. And for someone who may dissent and say, well, this just reflects more patients in the hospital, it's not necessarily an increased utilization, I will politely inform you that you're mistaken. So we looked at that and had that concern, so we actually broke this down into consults per 1,000 admissions. And in fact, inpatient admissions in particular are declining at Riley on an annual basis. And so this graphic actually demonstrates a more profound increase in the utilization of this service. Okay, so how about some of the nuts and bolts? Man, that's a lot darker on your screen than mine. Sorry about that. So patient age and demographics. So the number one patient population that we get ethics consults on here at Riley are for patients less than a year old. I think and that is pretty consistent with data nationally. I think one of the things that is interesting and is present in some of the other reports is this 12 to 15 and 16 to 17-year-old grouping that has a pretty decent proportion of the patients. And I think in my experience, this reflects the patient population where emerging autonomy is being respected and the values and preferences being voiced by adolescent patients carries more weight. And occasionally those values and preferences are inconsistent with those of their parent who is ultimately consenting to therapy for them. From a diagnosis standpoint, far and away the most common diagnosis from a system standpoint is neurologic for patients who have ethics consults requested for them, and then followed kind of bunched thereafter by pulmonary and developmental genetic malignancy, cardiovascular, GI. So who calls for consults? Most commonly physicians call, which is resident, fellow, a faculty, followed thereafter by nursing. I do highlight for you this someone else category. So here at IU Health, we hold that anyone can call an ethics consult and it'll be respected, and we take great pride in that. And I would just want to share with you that of these 22, 6 of these were actually families that requested the ethics consult. Not surprisingly and consistent with a lot of the other data, neonatal and pediatric ICU are the locations where patients reside most commonly when consults are requested. And whether that speaks to an unfair distribution of resource allocation to inpatient ethics consultation services over outpatient, or the acuity of patients and complexities of inpatient compared to outpatient is debatable, I think. So what do we do when we consult? Well, we make recommendations and we provide moral support for the team, among other things. I want to talk for a second about moral support for the team because this stands out as unique from our data in comparison to other reports nationally. And I think we have Dr. Boschel to thank for this, as she is a national expert in moral distress. And as such, I think we have a heightened awareness for this challenge that we face. And there is great evidence, terrible evidence, I suppose is the correct word, that says moral distress places providers in all disciplines at risk of leaving not just their job, but the field that they're practicing in. So us being able to be aware of that and provide some support mechanisms, I think, is unique and important. So don't get bogged down in the numbers here. The reason I want to show you this is just so that everyone who provides patient care can look up and say, holy moly, my job is really hard. Look at all of the ethical issues and challenges that I have to navigate while also addressing the medical aspects of a patient's care, okay? We'll talk about the top 5 ethical issues that are identified in these consults here momentarily. Before I move forward, it broke my heart that our previous consultation data summary sheet had this in there, and we have since corrected this problem, but this is a hill that I will die on, and that is that we never withhold or withdraw care from patients. We may discontinue a life-sustaining intervention or transition to comfort, but care continues despite the plan that is implemented. Okay, so jumping to our most frequent ethical issues identified. Number 1 was patient best interest, and this is not surprising. In the world of pediatric surrogate decision-making, patient best interest is considered the gold standard, and so that being identified and highlighted in a multitude of these consults makes good sense. Following thereafter by withholding and withdrawing, again highlighting provider moral distress, non-beneficial treatment, and then concerns about discussions for transition and code status. Okay, so we're going to take a half a second to clear our brains. This is my son, Lucas. 3 years ago when I gave this talk, I was just thinking this morning that I played a little video of a nonverbal 8-month-old pushing a VTech like musical train, and how now I have like a legit kid with me. And we have upgraded from trains now to fire trucks. We are fire truck everything, fireman, fireman hat. We are a fire truck for Thanksgiving, for Halloween. Not a fireman for Halloween, a fire truck. All right, beautiful. So let's make our transition here. So we talked about the history of ethics at Riley. We talked about the consult experience that we have had historically. And now we need to say, how are things looking currently? What is our culture here? What's the ethical climate? And in order to know what the results of that mean, we have to say, what's an ideal culture of ethics and ethical climate? And that is a hard question to answer. And it is not unique to a hospital. Many organizations can embrace a lot of these concepts. But a culture of ethics and a strong ethical climate is an environment where there is support for open dialogue, for expressing concerns and admitting mistakes, that is built on mutual respect, where people are accountable to one another. This trust mnemonic that you see here is in an article describing the imperatives to create a moral community, and there's good evidence that says a moral community supports a culture of ethics. And trust is just treatment, respect, understanding, compassion, supportive care with transparency. In a culture of ethics with a strong ethics climate, members should be encouraged to reflect and challenge. This next one I think is the most important, and that is that we have to give voice to values. This is something that's harder for us, right? Because we put our heads down and we say, asthma, what's the protocol for treating that? Diabetic ketoacidosis, how do we treat that? In order for us to embrace a healthy ethical climate, we've got to, I don't even want to say transition, but broaden our approach to the framework that we use for providing care to patients to be more holistic. So we have to always remember that we are treating a person first and a disease second. and that we aren't just treating a patient, we treat their family when they're here. And that someone who has values that differ from us isn't wrong just because those values are different. One of the very first meetings I had with Dr. Cox, I asked her, what would you say 10 years from now if ethics at Riley was perfect? What would that look like? And she said, well, what I would like to see is that every single patient that we discuss, a component of that discussion is ethical considerations. And so I don't know if everyone here is familiar with the idea of a SOAP note. Certainly the more tenured faculty are. And this was an approach to like a daily assessment for a patient. And it's subjective, objective, assessment, and plan. And so for Dr. Cox, I have created the SOAP-y note, which is subjective, objective, assessment, plan, ethical considerations for every patient. Okay, so this is great, but how do we actually get there? I will tell you that I think that this sequence of processes is the way there, and that is evaluate, educate, empower, and immerse. I was ecstatic when I thought of this, and then realized that immerse starts with an I instead of an E, which ruined everything for me because it was going to be E to the fourth. But the importance is still there. It's just not as clever as I had hoped. But so what does this mean? So to me, this means we learn the current state of affairs. We assess the preferences and needs of the individuals that are working with us. And then we make available the appropriate resources and build a support infrastructure so that we can have exactly what we're looking for, which is a strong ethical climate. So I had to assess what the ethical climate and what the needs were. And I was so fortunate to find a tool called the Clinical Ethics Needs Assessment Survey. And this was a validated survey that was used up in Canada. And I chose actually to transition to a structured interview and thought to myself, how can I maximize the responses without having to do a gazillion of these? And thought key stakeholders would be best to represent the needs of their respective divisions and people they work with. And so I interviewed the chair of pediatrics, key hospital administrators, and then every division chief in the department, and then nursing leadership as well. And it only made sense to me that managers and the division chiefs should be equipped to communicate the needs and preferences and ongoings of ethical challenges in their respective divisions. This is a 60-question assessment. Took about 40 to 45 minutes with each of the respective individuals, and it highlighted a handful of things, and in particular, it was perceptions of ethical climate, awareness of ethics-related policies and resources, and I don't know why I didn't put it in here, educational needs and preferences, and then experience of ethical issues. As I mentioned, this was a lengthy tool, and so obviously I don't have time to go through every result for you, but I do want to highlight a handful of things. Okay, so first and foremost, ethical challenges arise every day at Riley, probably multiple ethical challenges arrive every day. So for us to suggest that there is an alternative to improving the programming here and the infrastructure for ethics, I think we do ourselves and our patients a disservice. This was one of the questions on the structured interview. On average, how often do you encounter an ethical issue in your work? And whoever said never, I need to reach out to them. But as you can see, obviously, we encounter ethical issues very frequently. All right, so let's talk a little bit about the ethical climate and the perceptions thereof. So there are things that we can be encouraged about, and I think these are two of them: feeling respected by other staff members and being encouraged to express ethical concerns. If you recall, when we just talked about a strong climate of ethics, mutual respect was one of the things, as was providing an opportunity to reflect and challenge and express concerns. These two things exemplify that. Less encouraging, however, is the perception about transparency and consistency in the way ethical dilemmas are addressed, and awareness about how to reach out to people when there are ethical concerns. These are two of the more disconcerting response categories for me, but I think areas for great opportunity that can be addressed. And that is simply an acknowledgement that currently the availability of these resources, people are not aware of them, okay? And so access to ethics resources is promoted. Doesn't appear the perception of that that people perceive to agree with that, and there's not adequate ethics education. A couple of the questions highlighted some of the ethics-related policies or guidelines or legislation. I was encouraged that the majority knew about consent and confidentiality policy, not quite as much awareness about the approaches to organ donation or disclosure of harm. And I want to highlight the disclosure of harm because we talked about accountability being key to a strong ethical climate, and disclosure of harm is integral to being accountable to our patients, to our families, and to one another. All right, so do you know about the Ethics Consultation Service? Unfortunately, when you think about this, 6 key stakeholders were not aware that one existed. That's concerning, right? Same with Ethics Committee. So there is an IU Health Ethics Committee that people didn't seem to be aware of. There is an Ethics Consultation Subcommittee that similarly there isn't adequate awareness about. This was the one that really hurt me the most because at the beginning of each interview, I introduced myself and said, my name is Brian Leland. I'm a pediatric critical care physician here at Riley. When I'm not working in the PICU, I'm a pediatric ethicist doing ethics consultations. And then the question was, are you aware of an ethicist? Are you sure that you're not aware of an ethicist? No, pretty sure we're not. So, you know, at least it suggests that the responses weren't biased. So, all right, and then, so the ethics education was 2 parts, and the first was a series of questions saying, what are the approaches to education or models that you think are best served to meet the needs of your division? And then the second was, here's a list of 30 topics that are ethics-related content, and which of these do you feel are most important for your division? And so for part 1 here, just so you know what these percentages mean, the choice options were for ethics educational models, how much you think that they would meet your division's needs. Least preferred, less preferred, more preferred, most preferred. So I combined more and most preferred to arrive at these percentages of the responses. And so you see there's a pretty clear delineation after facilitated informal discussions. And so the most common models for education that seem to be consistent with the needs and preferences of each division are interdisciplinary team rounds, departmental rounds, and facilitated informal discussions. With relation to which content areas there was the greatest need for, and I want to apologize that for some reason I put percentages on the last one and then did gross numbers here. 30 was 89%, and 32 was 96%. I apologize, but I sent Annie 2 versions of this PowerPoint this morning, and I knew a third was going to not work out for me. So, but the things that people wanted to have maximize their education on were being provided with ethical decision-making tools, in essence, having frameworks in which to use to navigate ethical challenges, opportunities for personal ethics and reflective practice, resource allocation and priority setting, and then I've underlined and italicized these 2, which are communication with families and conflict resolution, because Dr. Boschel has actually a 2.5-day workshop called WISP, which, if you want to write this down, is April 26th to 28th of 2019, and the entire thing is focused on communication skills, and I quote, in particularly emotionally charged situations. So we do have a resource available for anyone that identifies that as a need for themselves and would be interested. It's small teams, 3 people's okay, right? 3 or 4, okay. And you can email fcme.org or you can email me and I will get you in touch appropriately as necessary. Okay, so one of the wrap-up parts of the structured interview was, tell me about your experience with ethical challenges. And I just completed the last of these interviews a week and a half ago, so this stuff is hot off the press and the formal qualitative analysis is in progress, but I wanted to highlight some of the recurring themes that we saw. And those included concerns about continuing forward with potentially inappropriate treatment. This was a really pervasive one, and that was, how do I know the line when to reach out to CPS when I think that there is a caregiver enabling or caregiver driven suboptimal compliance or non-compliance for managing a disease process. Concerns about quality of life evaluations, questions about limitations for parental authority, And then this one we see not infrequently as well, which is transparency with patients. So situations where a parent or caregiver would say, I don't want you to tell so-and-so that they have leukemia, or I don't want you to tell my critically ill child that she lost her leg, and how to navigate those situations. And then again, as we discussed, provider moral distress. All right, so then the very last thing was, what barriers do you see to utilizing the ethics consultation service? My favorite response to date, and by favorite, I don't mean favorite. So I rephrase that to say lack of awareness of its existence, and then time. So one of the concerns was we worry that the consult can't happen in an efficient time frame. I hope that based on the description that I just gave you for how we process through ethics consultations that I can smash that myth, and we can do urgent consults just like any other consultation service. It's not often, but occasionally we'll get a 2 a.m. consult about whatever it may be, and we're equipped as a program to be able to provide that service in an emergency setting as well. Lack of familiarity with the ethics team and the role of the ethicist. One of the respondents said, I don't feel like it's my place to say ethics should be involved if I'm just a consultant. I hope that if I tell you that a parent is allowed to request a consult, that any medical provider involved in the care of the patient who has concerns about ethical issues should feel empowered to do the same. I was very humbled that one of the respondents acknowledged that provider ego certainly plays a role, and that there is this misperception that reaching out to ethics is a sign of weakness. And then the long-standing misconception that if ethics is called, then someone is in trouble, or ethics is only called when someone needs to be told on, and that we're the ethics police. Okay, so we've just gone through a bunch of stuff, right? We went through the history of ethics at Riley. We talked about the consultation data that we had collected, and then the results of this ethics needs assessment, and have identified that this happens every day, that the service is growing in demand. We talked a little bit about high utilizers, what some of these disease processes look like, and that key stakeholders acknowledge the importance and want more infrastructure, but don't have appropriate awareness or education. So now what do we do? Well, I think we talk about how we use this information to inform program development moving forward. But before we do that, I just want to reiterate that we are a real thing. There's the Fairbanks Center for Medical Ethics. There is even now an IU Health Department of Ethics. We have like a cost center. We're completely legitimate. So know that we are here and that we want to help. Sorry, not sorry for not asking if I could put all of your likenesses into the cheerleader picture, but I did it. All right, so specifically here for Riley, what I envision is a 3-pillar foundation built on service, education, and research that can carry Riley forward in the world of ethics. But before we worry about each individual pillar, I think it was really important that we had a foundation that could reinforce each of them, and that being a very senior, high-level leadership council. And so back in February of this year, we formed the Riley Ethics Senior Advisory Council. And the goal of this entity is essentially to shepherd all of the initiatives and program infrastructure as we move forward. This currently consists of the CMO, IU Health Nurse Ethicist, social work leadership, our IU Health Director for Clinical Ethics, a senior physician who is a neurosurgeon here with us and has been practicing at Riley for an extended period of time, nursing leadership, which is now vacant and we need to fill that position, and then me. So we're going to go through each of those 3 pillars and where things, services that are currently available, and then anything with an asterisk next to it is an upcoming program that we will be offering moving forward. So I hope that we can all know that the ethics consultation service is available now. One of the things that we're considering is, do we introduce some proactive ethics initiatives in some of the higher utilizing areas like NICU and PICU, and that's a work in progress, and that's very much in its formation stages. We have available unit-based ethics conversations. This is Dr. Boshel's baby, and this is essentially an opportunity for team members who have struggled with a very difficult case to have an environment where they can emote, where they can communicate, share values, vent, challenge. And this is integral to supporting individuals with moral distress. And I'm so excited that we can do this. And if ever you need this, you can either call the pager and we can coordinate one of these, or you can email myself and we'll work to make this happen. But this has been something that's been highly utilized. I know Dr. Boschel did one sometime in the recent past where like 20 or 30 people came because of how challenging a certain situation was for them. All right, so we talked about promoting awareness. So one of the things that I'm going to start doing starting January of 2019, if they will have me, is attend one of the monthly faculty division meetings for every division in the Department of Pediatrics annually. I hope that this will remove some of the discomfort with the relationship between ethics and some of the medical teams and provide an opportunity for a non-formal discussion, which was number 3 on the preferred means of education. And then I'm ecstatic to share with you that we're going to be putting out a call out, if you will, for the new formation of a pediatric ethics committee, subcommittee. We're waiting to hear from IU Health which of those we're allowed to call it. But that will be in early 2019. And this is going to be a multidisciplinary, very structured group with a formal cabinet, with educational curriculum that I'll share with you here momentarily, with a goal that every discipline in the hospital would be represented, with a liaison to then communicate back and forth between those disciplines and the committee/subcommittee. All right, education. So education, I think, is something that we can kind of jump on and ride quickly. There's good infrastructure in place, and we can grow it, I think, in a healthy and sustainable way. So if you didn't already know, you are currently in the FCME lecture series. And about a year and a half ago, maybe 2 years ago, we went from having almost exclusively over at Methodist to having it alternate here between Riley and Methodist so that we could expand the population and audience. And we make every effort to specifically have PEDS dedicated topics when we're here at Riley. And I will further that by saying I will try to make it so that the topics that were identified as the highest need from the needs assessment are the things that we try to focus on for content while we're here. It's always on a Wednesday. It's the first Wednesday of each month at noon, and it runs from September to May. Pediatric grand rounds. So starting in 2019, my plan is that we will have 1, if not 2, grand rounds focused on pediatric ethics here at Riley, both from local and invited speakers. And then I shared with you that we'll have a structured curriculum for this PEDS ethics committee/subcommittee. And so what I envision is that we'll have quarterly meetings, and that at every meeting, after review of the consults and updates on initiatives, that we will have a TED Talk. I hope that's not a copyright infringement. If it is, I'll call it something else. But essentially a 15-minute high-yield discussion on one of 8 topics that will happen on a rotating basis over 2 years, with a supporting article to reinforce or dive further on that topic. And the goal then being that as people rotate into and out of the subcommittee, that they would be exposed to the entirety of the foundational curriculum over a 2-year process. All right, I already do some resident and fellow education, but I will formalize that so that there are 2 noon conferences every year for the resident trainees, and then annually a fellows workshop, both of which will be foundational principles in pediatric ethics. I also am excited to work towards offering annually a faculty development workshop, because I know obviously that faculty don't have protected time for noon conference the way that some of the trainees do, so that we can make available those educational opportunities as well. And then I would call this a shameless plug, but I don't think it's shameless. It's a proud plug, and that is, as the fellowship director, I would feel remiss if I didn't say, if you look at all these educational opportunities and you just say, yeah, these are great, but like I really want to dive in head first, well, then you should consider the FCME Clinical Ethics Fellowship, which is a 9-month certificate program. It's August to May, all day, every Wednesday, and is focused on 3 parts: a seminar and didactic session where you will get the core principles in clinical ethics, a consultation experience where you will do a month of consults and have didactics to teach you how to perform the consult, as well as become competent in writing an ethics consultation note, which you would never believe how hard that actually is. And then we mentor you through a scholarly project as well, focused on an area of interest of your choosing. Applications for that are March 1st, and you can go to the FCME website to find that. And we're going to have February 28th a lunch and learn at Fairbanks to share more in detail about the fellowship if you have any interest. And I'm hoping we'll be able to do one at Riley, but I'm not positive that's going to happen. Lastly, research. Wanted to just highlight, we talked about the first two on there in detail today. A couple of the other ethics-related initiatives that are ongoing. We have a pilot study going on in the Pediatric Intensive Care Unit right now called BLEND, which stands for Bridging Language Effectiveness for Organ Donation, where we are assessing the impact for families and for faculty and fellows on allowing the physicians to introduce to families the concept of organ donation and bridge the gap to introduce them to the organ procurement organization, to try to improve upon what functionally has evolved into a secrecy plus ambush because of issues with unplanned mentioning of organ donation in any way, shape, or form for patients who would be eligible. And I'm excited to see what the results of that are and potentially move that into a multi-center study with a PCORI grant. Dr. Boschel and I have recently submitted an R13 grant in collaboration with a physician at Columbia University, where we hope this coming year in the fall to host a national conference with about 16 experts across the country to establish best practice guidelines for pediatric prolonged length of stay PICU patients. But we are awaiting review of that grant. I know Professor Hartsock and Amy Martin, who are our two newest faculty in the ethics department, are working together, and we will at some point here begin a process where we have an opportunity to review the perception of the consultation quality with those who have requested it, so that we can continue to tweak that and improve upon it to better meet the needs of those that we're serving. And then I do want to just congratulate again Kim McGinnis, who was awarded a small grant for a project called A Day in the Life, which is a video that she created with families of patients who pursued tracheostomy and chronic mechanical long-term ventilation, to essentially be able to illustrate what a day in the life for a family in that situation entails for families that are in the process of making those decisions about whether or not to chronically trach and mechanically ventilate their child. So you can see that there are a lot of seeds being planted, right? And there are some that probably won't grow, but I think that the future is really bright and that we are going to be in a very good place in the near future and an even better place in the distant future. And I hope that I have motivated all of you to, at the very least, acknowledge the importance of supporting these initiatives, even if you don't have the bandwidth or capacity to actively participate in them yourself. I think that is it. Yes, want to thank everyone. There are a bunch of people not on this list that I would like to thank, and I would be happy to field questions, and I appreciate your attention.
Brian, in your mentioning there, you mentioned like PEDS department subspecialties and PEDS department grand rounds and PEDS. What about all the departments with doctors that aren't housed in PEDS, like dentistry, all the surgical, neurology, psychiatry, etc.?
Yes, I would say that. The question was, the focus of the presentation was pretty specific to the Department of Pediatrics and what our thoughts about pursuing approaches to program development for non-Department of Pediatric services like dentistry, psychiatry. There were a couple others mentioned. Is that correct?
And all the surgical
And all the surgical departments. So I will share with you that that needs assessment did include the Department of Neurosurgery, did include pediatric surgery, did include psychiatry. Yes. So while being able to feasibly reach out to every single person and coordinate that wasn't a possibility, the short answer is that I think we have to take it in chunks, and this is the first big chunk, and that we can then reevaluate the success and challenges that we've experienced and reform it, and then have an opportunity to utilize an even more successful model to implement into other various areas of the hospital. But I agree with you wholeheartedly that the Department of Pediatrics does not support the entirety of Riley Hospital for Children.
Hi. I have two questions. The first one is, do you guys have kind of an established relationship with DCS, Department of Child Services?
Oh, sorry, I thought you were going to ask both questions. I was waiting. So I think the short answer is no. That I would say the group that probably has the most tightly established relationship with DCS, and I don't want to speak out of place, but it's probably our social work group. And, you know, obviously, as I mentioned, we have a social work leader representative in our Riley Senior Advisory Council, and I would hope and frankly expect that we will have one or more representatives in our Pediatric Ethics Subcommittee as well.
And then number two, does this extend to the outpatient world?
So the question is, does this extend to the outpatient world? And I guess, what is this? Yes, yes, outpatient consults are available. And sometimes those are a little bit trickier because it requires coordinating a future visit to attend. But I have done that, yeah.
Because I'm a medical social worker over at Eskenazi, so I've been over there 18 years. So there's a lot of the same faculty, physician, and so they are always seem really open when we have challenging cases. And so I just didn't know how out there the information was within, you know, other health systems, physicians to place those consults.
Yeah, we should speak in more detail afterwards to make sure that I can know exactly what it is that you're asking. Other questions?
When there was the comment earlier about additional services and groups and like dentistry and that, with more and more maternity care being provided at Riley and that expansion, how do we see consults working going forward as far as managing the adult piece of the maternity care and the potential pediatric piece? Do you see that falling under pediatrics? Do you see it falling under the adult consult committee? What does that look like, or what do you see?
I think that we will have to see, you know, as the mother-baby tower gets built and that becomes more specific to Riley, it may be logical to transition the focus of those into the pediatric realm, but I think it will ultimately depend on the nature of the question that's being asked.
I have a question from Ball Memorial. Any study on what effect ethics consultation have in patient and family satisfaction scores?
Oh, interesting. So off the top of my head, I can't speak to specifically satisfaction scores like the, you know, survey that a family fills out after they leave the hospital. But the literature that does exist communicates that the perception is that involvement of an ethics consultant facilitated progress in the patient's care.
Is somebody else in front of me?
Yes, but
okay.
You can talk and then she can talk.
No, it's fine.
Well, she doesn't have a microphone.
Oh, I see. Okay. All right, well, mine is brief.
Okay.
So TED Talk is copyrighted, but what about PEDS Talk, P-E-D instead of T-E-D?
Perfect.
There you go.
A PED Talk, okay.
Hi, I don't have a question. I have a comment. As one of the PICU physician and the large beneficiary of the ethics consultation program as shown in your previous data, I would like to speak to the fact that the ethics consult really has been incredibly impactful in the practice in PICU, and the promptness at which we receive these consults have been amazing, including requesting a consult at 4 p.m. on Friday and a consult happening in the next half an hour in a child where we are talking about potential crucial decisions in the care that was going to occur farther down the line. So thank you.
Thank you
To
for
all
that
of
vote
you.
of confidence.
And also, the consult was not performed by you because you cannot do consults in our group due to conflict of interest. So was somebody else in your team who came here Friday afternoon, close to 5 o'clock, to do this consult.
Appreciate you sharing that. Yes, sir. Wait 1 second for the microphone so that the satellite.
Since dentistry came up a couple of times, and I represent pediatric dentistry and orthodontics here at the hospital, one of many. We had an individual from dentistry go through your certificate program, Larry Goretto. Are you familiar with Larry?
Yes, and you had
2 people.
Suzanne Benedict, who was
Yeah,
actually
so
in my class as an ethics fellow.
I don't know that they've ever come over and I'm not sure we've ever reached out to engage with them, but we need to.
Yes, I will share with you, thank you for saying that, that I know Suzanne has established a curriculum for the dental students focused on, I want to say, decision-making capacity in older adults that are receiving their dental care, and helping them assess whether or not they have that capacity and whether or not it's appropriate to move forward with an intervention that's planned that day. So there is some infrastructure working there, and I'm sure Suzanne would be excited to do other things as well. Benedict? Mm-hmm. Any other questions? All right. Thank you so much for being here. We'll see you in 2 months.